So I'm going to be talking about modeling labor progress, which in the obstetrical intrapartum context means following, tracking the dilation and the fetal station. Dilation is referring to the condition of the cervix, and the station is the fetal how far the fetus has descended from the uterus into the birth canal. These pelvic exams are done throughout labor. I put a number there. It's very, very variable, but the obstetricians like to do this quite frequently because it gives a sense of how labor is progressing. So a little bit more specifics, especially for the engineers. The cervix is located at the bottom of the uterus, and it begins completely closed or at 0 centimeters and progresses through to 10 centimeters by the end of we're talking about the first stage of labor, which 10 centimeters defines the end of the first stage of labor. And the effacement is referring to the thinning of the cervix itself. And you can see this in this plot here. Maybe not. Okay. So from A to D, we're going from early labor to later labor. I wish I could point to something here. I can't point. Okay. So at the base of the baby's head, you see 2 flaps that are closed, and just point there. Just point on the screen. No. Okay, it's okay. It's okay. It's okay. So in B here, you see the flaps starting to open. This is a few centimeters of dilation. The effacement, the thickness, is still there. Moving along to C and finally D, you see that the opening is becoming more and more pronounced. By D, it's about 7 or 8 centimeters, and the flaps are very thin at this point. So the effacement has achieved the thin side, the 100% effacement. Fetal station is measured with respect to certain landmarks in the pelvis, starting from -3 at the beginning and moving towards +3 towards the end. Most obstetricians will be familiar with this Friedman curve in their training. Dr. Freeman from New York started his work in the 50s on characterizing labor progression, and basically it has been a stalwart part of how obstetricians view dilation progression. Basically, he took several hundred cases, or moving into 1,000 cases, and you played with this curve here, which is a fixed curve. There's a beginning latent phase until time 0, and time 0 is defined as the beginning of the active phase, and the active phase follows this exponential function at that 2.3 baseline, which is the 2.3 centimeter level. And from this, Dr. Friedman generalized to many dilation profiles over time, and the active phase, he had this calculation of the angles and so forth to arrive at this B point, which he defined as time 0. Now, this is basically looking at labor progress from a point of view of time only, and it was never really put through the rigors of a data-driven model, which we've been using these days, and this kind of provides a context for our work, was to let the data describe how this dilation profile actually works. The other thing to say is that in practice, clinicians are given certain guidelines to keep in mind. If this active or latent phase, this flat phase, lasts for 2 or 4 or 6 hours, depending on the guidelines, that's considered concerning and time, what clinicians call arrest of labor, and that can provoke a C-section. It might not be at the very beginning. You might get some progression of the dilation to a plateau that does not progress further. But in practice, clinicians rarely follow these guidelines very well, and so having a model of labor progress would be very helpful if it could inspire more confidence in the clinicians, because clearly, as much as Dr. Freeman's work took labor progress into the modern era, it did not have enough capacity to describe the variability of labor. So in our model, we had these candidate predictors to come up with a prediction of the dilation and the station. I'll talk about that a bit later. I'll just focus on the dilation prediction first. So we used the time since the first recording, or time 0. We used the cumulative contraction count since time 0. Basically, the idea is that labor cannot progress without the presence of contractions, and usually labor is defined by the presence of contractions. So this is part of the model. At any point in time, we look at the dilation that has happened in the past, as well as the effacement and the station. And we have a couple of categorical variables, induction and rupture of membranes, whether these conditions were present or not. In the end, our model did not need the time itself. It seems that the cumulative contraction count was enough, and also the rupture of membrane status was not so useful, perhaps because we were only looking at the last 24 hours of labor, and rupture of membrane could have happened earlier, or it simply was not sufficiently predictive. We haven't explored that, but these 5 predictors were our final set. Now, our baseline model was a model that my colleague Dr. Emily Hamilton developed in the 90s, which was a mixed effect regression model that would predict the dilation at any time t as a function of these regressors, these predictors. Dr. Hamilton actually had a bigger set, a few more. The rupture of membranes was actually used in the original model, but for comparison purposes, we used the model, the set of predictors that our new model used for an apples for apples comparison. So you see that we're predicting the dilation at the current instant in time based on the history of those three observations and the count of the contraction and the categorical variable, the epidural. And basically, we are doing this at every instant in time, comparing the predicted dilation with the observed dilation. So we do this calculation once a new exam comes in, and we compare the current observed and predicted dilation. Now, for our new model, we used a Gaussian process model because it did a pretty good job of modeling sparse data, and this quite accurately describes how the labor exam model arrives. It arrives when it arrives. Sometimes we have 2 or 3 exams. Sometimes we have 10 exams over the course of labor, and they can happen at many instances in time. So we need a regression that is capable of handling any time interval, and the Gaussian process model does this. And Peter has described this to this group many times before, so I won't go into the details today. But suffice it to say that it's a Gaussian. It's predicting not like in a parametric model where you predict an outcome variable with a given standard deviation, but the idea is to actually predict a family of functions. And when you predict a family of functions, you not only get a prediction, you get a confidence bound around those predictions. And this is a pretty useful thing for medical signals, so that we can give some confidence to the clinician about how much they should trust. Here are the equations. Here's a few example outputs. On the left, we have a normal labor that is progressing from 0 centimeters to 10 centimeters. You see on the bottom left most clearly the dots, the black dots are the observed dilations, and the pink lines are the predicted observations with the confidence bounds around them. On the right is an abnormal labor, or an arrested labor, and you see, as I mentioned before, that it gets to a certain level, say 7 or 8 centimeters, and stops, or it just does not progress enough. We're already at hour 30, and we've kind of settled on at 8 or so centimeters. So this was in our data, that was the end of the data, and there was a C-section. So that's the most clear way of understanding the two models for these kinds of cases. The pink band is the confidence band given the training data set, and the blue band is the confidence or credible interval given not only the training data but also all the test data to date. So once you have a general training model, you can use this, you can update it with the actual data that you're seeing up until that point. And again, we're always looking only in the past for our predictions. This series of plots is comparing the two models, one based on time alone on the left, and one based on the full set of predictors. And this is the error in prediction over time, or since the last exam. So we're looking at how much time has elapsed in making our current prediction. And as you see, the errors are quite large when we only consider time, which is often the case for most clinical models, like the Freeman model. And on the right, you see the Gaussian process model with the predictors that we have been using, with significantly less error, and the confidence bounds around those errors are quite tight. This graph is showing how much standard deviation we have in our predictions, which is gives a sense of how confident the model is about its prediction. On top is the baseline model, which was the mixed effect statistical model, regression model. On the bottom is the two forms of the Gaussian process model. The one on the left is 5P, is the pink, referring to the pink band, so that's based on the training data alone. And on the right is the reduced error after we actually have seen data to date, what we call the test error. And these confidence bounds are quite a bit less compared to the mixed effect. So this model is more confident in its predictions than the statistical model was. One of the outcomes of the last SPAM conference was this call for papers, or maybe it was a completely independent proposition. We responded to this, and we presented our results in this paper. In addition, we had a complementary clinical paper which was just published in the American Journal of Obstetrics and Gynecology, and Dr. Hamilton was the lead author on that. On the technical paper, we had a PhD student from North Carolina State University, Tilek Zwarov, and he brought a lot of Bayesian experience to the development of this model. This report of major impact was quite an honor to receive this. The AJOG only gives this for a few papers every year, and so this is what we have. The conclusions are that we have a more accurate prediction, and we have more confidence in those predictions. And this is something that is really, really nice to go to this next step of recommendation. We haven't gone that step yet. We just wanted to make sure that we could predict well, and now we're in the process of interpreting those predictions, and in the sense of, are we in arrest, or are we not in arrest? Should there be a C-section or not? Thank you.